Dr. Thạch Nguyễn, should we start our presentation? Anh Lâu ơi.
Yes, I'm here. So we need to waiting Dr. Santos a few minutes.
Yeah, let me call him because I just talked to him.
Yeah, here.
Oh, he is in. Okay.
Hello, Dr.
Yes, you are in, right? But your phone, your speaker is not on.
Okay, I'm gonna call. What do I do? It says call using internet audio.
No, you see, you in the left lower hand side, lower corner, you have the two icons. One it is a speakerphone and one is the video, and both of yours both yours are off. You have to click it to turn it on. I see.
Okay, can you hear me now?
Yeah, let me check. Okay, you are on. Yes, you are on. Okay.
Okay, good.
Oh, we see you too.
Oh, good.
Okay. Hello, Lau. Are we ready?
Yes, we are ready.
Okay,
so today we have Nguyễn Bá Minh Phúc will present the case, and so I would like to introduce Dr. Santos, who will address for our class today. And hello, Dr. Santos. Yes.
Hello, doctor.
Yeah. And so Phúc, it's your turn.
So our today's topic is ARDS. So I'm Phúc. It's an honor to be with you today. Without any delay, let's just start our presentation. Our patient name is Nguyễn Huỳnh Nhật Khánh. He's 28 years old. He's male. And his chief complaint is dyspnea. On the first day, the patient has fever, fatigue, dry cough, but no dyspnea, anorexia, insomnia, fatigue, no dysuria, yellow stool, epigastric pain. On the fourth day, patient went to Suna Hospital for a health check, and he was diagnosed with gastritis and duodenal ulcer. He was treated with gastritis and antipyretic drug, but only his fever is relieved. Drug is unknown. On the 12th day, his fever got worse, shivering fever, and more prominent at night. At 22 p.m. evening to the 3 a.m. the next morning, his dyspnea was more severe and prolonged throughout the day. He would feel like drowned and had to take a deep breath. Dyspnea was increased on exertion, and he didn't have orthodyspnea. Anorexia, insomnia, fatigue, feel aching throughout his body. His dry cough got worsened. Cough all day, palpitation, dull chest pain, no radiation, non-related with exertion. Patient didn't have edema, and he urinates 7 times at about 1.5 liters, no dysuria, yellow stool, and no stomachache. On the 7th day, he fainted his company. His colleague found him lying down at his office with his body turned to purple, and he immediately got admitted to Tân Phú Hospital. At 16:30, then transferred to Trung Vinh Hospital for further management. This is the admission at vital site in Tân Phú Hospital. He's alert, oriented. Cardiovascular exam is unremarkable. Respiratory course correctors, decreased left lung sound. His vital sign is his SpO2 is 80, with cannula oxygen 5 liter. His temperature is 14.8. He got managed with paracetamol, 1 gram, sodium chloride, aspirin. This is an admission signed in Chungwon Hospital. His vital signs, his pulse is 100 beats per minute. His temperature is 39.8. His blood pressure is 160. Respiratory rate is 80. His weight is 65 kilograms. His height is 1.65 meter. His BMI is 23.8. He has lost 6 kilograms since the onset of fever from 71 kilograms. He is alert, oriented, peripheral cyanosis, autocandidiasis, and no bleeding. His past medical history, he has an LGBT lifestyle. Anything else is unremarkable. His cardiovascular system overview. He has chest pain, complaint of chest pain, palpitation, exertional dyspnea, and he has a dry cough. On a physical examination, 1 day after admission, the patient is fully awake and respond. His Glasgow is 15 point. His pulse is 107 beats per minute. His blood pressure is 110 and 70. Respiratory rate is 22 per minute. His temperature is 38.5. His SpO2 is 90 with oxygen cannula as 5 limit. He has a peripheral cyanosis, a cold hand, oral candidiasis. In cardiovascular is loud S1. He had an X3 at the apex, increased YXL. His respiratory is, he has a lungs percussions, hyporesonance and bilateral lungs, coarse crackle at the base of the left lung, increased tactile parameters as both lung fail. He complained about his fatigue, but abnormal musculoskeletal nervous system shown unremarkable sign. His muscle strength is 3.3. Summarize, our patient is 28 years old, male, with dyspnea. His symptom is syncope, cyanosis, fever, dry cough, and lose weight, insomnia, fatigue, anorexia. His sign is S3, SpO2 is 90 with cannula 5 liter. Temperature is 38.5. Peripheral cyanosis, pale appearance, oral candidiasis. S3 at apex, now S1. He has a hyporesonant bilateral lungs, coarse crackle at the base of the left lung, increased tactile parameters all in the lung, and he have LGBT lifestyle. And in this case, his main problem is ARDS, potential acid-base imbalance, acute heart failure, infection, and immunocompromisation. I think of about ARDS because the patient has cyanosis, increased respiratory rate, and he got decreased SpO2, even cannula 5 liter. So I think mostly of the ARDS. So this can lead to acid-base imbalance. By his infection, he also have a fever. Anorexia, insomnia, dry cough, consolidation of lungs, such as a pneumonia. About acute heart failure, S3 was due to, I think S3 is due to could be due to hyperdynamics of vascular system, but could not rule out disease that caused diastolic dysfunction such as HD, ischemic heart disease, hypertrophic cardiomyopathy, and the patient has cold hand and S3 at the apex, coarse crackles, distress at the base of the lung, such as cold, wet, acute decompensated heart failure. And about the immunocompromisations, the patient has LGBT lifestyle. The patient is young, his condition get worse quickly. So I think of this and raise concern about regarding immunocompromised status of this patient. This is his lab result. He got an increase in white blood cell, a little bit decrease in lymphocyte. Platelet is normal. He don't have anemia. His HCT is normal. This is the complete blood count after 1 day after the admission to the hospital. He have a low potassium, 7.8, 7.5 pH. A low PA is O2, and normal HCO3. There's no abnormal in his urinary analysis. You have a normal GFR, so about 118. You have a low potassium and increased lactate plasma. He has a little bit increase in troponin I. He has positive with HIV antibody. And this is his ECG. He has 115 beats per minute. His PI interval is 0.30 milliseconds. His QRS duration is 0.07 milliseconds. He has a nice and smooth airway progressions. Tall airways are lead V3, V4, and V5. ST is a neutral electrical line and no abnormal T wave. Well, discussion, I think, according to the lab test, the patient clearly had according to clinical, the patient clearly had respiratory acidosis. But the patient's HPS was about 7.5, suggests a mixed acid-base disorder. Respiratory acidosis, his ARDS with BaCO2 less than 60 and normal BaCO2. So I suggest this is ARDS type 1 with normal. HCO3 is confirmed acute respiratory failure. About his metabolic acidosis, the patient didn't have any dehydration sign, no anemia, normal HCT, and normal bicarbonate. So at this stage, you can confidently use the bicarbonate without any destructive bias. And this was not a contracted alkalosis. Normal HCO3 could also rule out the metabolic acidosis caused by overproductions of ACEs, and RTA is a disease group. And about the prognosis of this patient, the patient's consciousness still remained intact. It was a good sign that the compensated mechanisms successfully regulate the acid base for the CNS circulation. His respiratory system was 18 times. He breathed with 18 times per minute. His thoracic muscles worked well. It was not obesity. Only threat was low potassium, which could also lead to arrhythmia and diaphragm paralysis. His BBS system, which is bicarbonate buffer system, which is mainly in the muscle. So I think the patient have a normal blood pressure, normal plasma sodium. And I think so this could lead to perfusion, well perfused of the musculoskeletal muscle. But we still need venous CO2 for the further confirmation. Renal system, his GFR is normal, renal perfusion is normal. Renal acid-base regulatory should be intact, even though the renal regulatory mechanism is not significant in acute phase of disease compared to the BBS, but it contributes largely in long-term regulation of acid disorder and the recoveries of the patient. So at this point, our patient doing well. But we still need to monitor to detect constantly detect our patient's status. So in this case, I diagnosed our patient with ARDS type 1 caused by pneumonia. And he has a good prognosis. So my presentations end. Does anyone have any question?
Well, very good presentation. Very thorough. Can you hear me?
Yes, doctor.
Yeah, so I'm just looking over what you said here. So you had a very young man that came in extremely ill, obviously very short of breath. You know, there was a high white count, obviously hypoxemic, and very important few things that you noted on your physical exam, which I want to commend you. You know, you had mentioned something about the S3. S3 is very pathognomonic for congestive heart failure. So obviously this guy was apparently in what we would call multi-system organ dysfunction. He's having abnormalities, obviously in respiratory, but also cardiac wise. My question to you is, obviously, you know, his social history of being, you know, LBCDA, and also he came up HIV positive, you know, and you said that he had pneumonia. Would you think of any specific organisms that would be very important to cover in someone in this demographic, or would you consider him just regular pneumonia when he first comes in?
Well, the patient is quite abnormal because our patient is so young, and I forgot to mention that the patient looked very healthy. His BMI is 23.8, and his appearance looks very muscular, very healthy man. But he admission with cyanosis, so this is very abnormal. And with his social history like this, I suggest that he quite possible that he have HIV. And in this interstitial like interstitial pneumonia, I think that the patient could have PCB or tuberculosis, and these two bacteria is largely contribute in our country.
Excellent, exactly. You know, you always want to think about those opportunistic bacterial infections that would, you know, affect patients with this type of disease. So that's very good. You know, the one thing that you said that, you know, obviously you're diagnosing ARDS, but it's important for you to visualize that what caused the ARDS was the pneumonia. Now, also, what's another diagnosis you think the patient had when he came in that you didn't mention? So obviously you have pneumonia, you had the acute respiratory failure, you had congestive heart failure, and he was very sick. If you put that whole syndrome together, what was he also when he came in?
You mentioning about the septic shock?
Correct. I'm alluding to that. So remember, sepsis, septic shock is actually a continuum of the disease process of the multi-system organ. So initially, if you just have vital signs abnormal, laboratory things abnormal, and what would you call that?
Shock.
Not yet. So in the very beginning, it's a spectrum, right? So if your body is starting to fight something, you're going to start to have increased heart rate, increased respiratory rate because it's trying to fight something, right? And mounted fever to fight an infection. What do we call that first?
Infection, inflammation.
Right. So that would be called SIRS, so systemic inflammatory response syndrome. And then for your patient now, you found a focus of infection, correct? Which was the pneumonia. So that made him, what you said, sepsis, right? So that if you have that organ system that's responding to something that's making an inflammatory response, you have SIRS. And then when you found the source of infection, which you did, which the pneumonia, now he's septic. Now you said septic shock, correct? Was your patient septic shock?
I did use the quick SOFA score, and his score, quick SOFA score is only 1. So I don't think that's septic shock. And in and I did have ponder this question to myself that is the HIV patients that in this HIV patient like this, can I use the SOFA score? Because
You could use the SOFA score on any diagnosis. So SOFA score is a scoring system for you to diagnose the severity of anyone's illness. So if anyone that comes in with any type of hemodynamic instability, they are septic, and for them to be in septic shock, you could use that score. That's why we use that scoring system. Because once you diagnose that someone is in the sepsis syndrome, that would trigger a cascade of treatment modality or plans that has been standardized, by the various committees. Critical care committee, especially here in America, we use the CMS guidelines. So it would trigger, broad spectrum antibiotics, IV fluids, pressors as needed, a whole cascade, which was probably too in depth for this conversation. So you're exactly right. The SOFA score is probably the standard that we're using now. So very good in that regard. So your patient was not in septic shock. Okay. Now, you also said that, there was one thing that you mentioned. The patient had oral candida. Okay. Now, considering that he's HIV positive with a pneumonia and he lost about 6 kilograms, the one thing you should always think about is just regular HIV syndrome. And that can present with pneumonia the way like this. So very good there. Now, in terms of the ARDS, fabulous way to diagnose and how you presented that with the numbers and stuff like that. What's the treatment for ARDS?
In ARDS, usually I don't have any guidelines, but usually when I I study in the hospital, is very luckily that our patients is like he respond with the oxygen cannula. This is a good
Right.
sign.
You're already doing it. It's supported measures. So you would treat the underlying cause, which was the pneumonia. Now, let's say your patient got a little bit more ill. So you're already established he's in acute respiratory failure. He's at 5 liters. If he becomes more dyspneic, and obviously if you went up to the next thing, which would be high flow oxygen, or whereas he's on a non-rebreather bag, or then the next thing would be, what would you put the patient on? Let's say he's getting more hypoxic. What would your next treatment offer him? No, we're just focusing on the respiratory failure. So that's what ARDS is. ARDS is actually the end result of acute respiratory failure that unfortunately keeps attacking the parenchyma of the lung, that you start to have intense amount of inflammation in the lungs. So therefore that's the pathophysiology. The lungs get so inflamed and engorged that there's poor gas exchange in the lungs. So what would your next first? So the patient's getting more, in severe distress. You need to oxygen. He's now hypoxic. He's now on a venti mask, or non-rebreather bag, which is 100% oxygen. You need to give him more oxygen. What would your next choice be?
I have to prolong this state to cure the underlying disease, which is pneumonia.
Right.
In this case. Oxygen is
well,
needed.
you want to keep on giving him oxygen, right? So
Yes.
well, you need something stronger than this, the valve. So you need a machine, right? You need a ventilator, correct?
Ventilator, yes, correct.
Yes. So 2 types of ventilation is non-invasive pressure ventilation, and of course, invasive ventilation. I mean to say, non-invasive means to say it's just a mask. That's what we usually call BiPAP. It's still a ventilator. But then let's say your patient gets very sick and needs to be intubated, and now he's on the machine. Is there anything that you should consider to do when someone has ARDS on the ventilator?
I didn't know the English term of this, but in Vietnam we call it nội khí quản.
I don't know what that means. I'm sorry.
We typically we put tube right directly into our patient bronchi.
It is intubation.
Oh yes, of course. So you're going to intubate, but there's a specific treatment that's very standard that you want to do to make sure when a patient has ARDS on the mechanical ventilator in terms of your setting. So I'll leave that for you as your homework, and you could email me or Dr. Nguyen to look that up. Right, Dr. Nguyen?
Very interesting. Uh, that is very good, because you know that even very good, because even I'm a cardiologist, but I did not learn a lot about intensive care medicine. So today, Dr. Santos explained many things about from the non-invasive to invasive to the to the highest level of treatment for the ARDS with intubation. It's very good. So at this point, Dr. Santos want to give to Fook the homework to go what is the next step and what is to do when the patient is intubated. So does anybody have any question for Dr. Santos? In this case, it is ARDS.
I'll give you a tip. It's something to do with the tidal volume. Well, excellent presentation.
What's the question, please? I could only think about using
It's okay. You know,
I could only think about using
don't worry. Don't worry about it. You'll read on it, and it'll spark some interest in you. Okay. Obviously, your patient didn't get that sick, so, but excellent presentation.
Honestly, I right now only think about corticoid to suppress the patient inflammation, then could get better with his alveolar. But to try back, get worse.
You're close. You're thinking in the right way. You're thinking in the right way of what the treatment is with the ventilator. You're very close in what you're thinking.
But I never use that because it will largely increases infection. Very dangerous.
So you're already controlling the infection. Go.
Foucault is concerned that if we give steroids, we diminish the inflammation, but we can increase the risk of superinfection, a superimposed infection. And you mentioned that we already cover that with antibiotics. But in conclusion, what's wrong with this patient? Does he have AIDS or what? Because it is a lifestyle, and then he had pneumonia. But why a young patient with pneumonia and becomes so sick? Ian, what do you think? And you have to explain to me because I don't understand.
Excellent question there. Actually, it's interesting that you raised the question about steroids. Actually, there was about, I think 5 years ago, there was the Chest Society had come out with recommendations. There is mortality benefit to give steroids to people with pneumonia, a short 5-day course of about 20 milligrams of prednisone. So at this point, the Society of Chest is saying that pneumonia is an inflammatory disease that can actually be benefited by giving steroids. Now, in this patient, it would be quite challenging to say, should we give steroids or not, knowing that there's a possibility that the patient could be immunocompromised. Now, as you know, we see a lot of pneumonia, but this patient seems very, very ill. And I think the compounding thing is probably the HIV status. And, very astute, your student had said, you need to make sure to cover PCP pneumonia and, other opportunistic infections, obviously tuberculosis, if it's endemic in that area. And, probably a good workup of the lung and other regular causes of infection is important. Yes. Now, is it typical? Do you guys give steroids to pneumonia patients in your country?
We use it quite a lot. And
Good.
in tuberculosis, like it's the compilation of tuberculosis, like meningitis. We just drop in and we use venous venous dexamethasone. As I remember, it's like 5 milligram, and the 2 dose at the morning and at the evening. Like
Excellent. Good. Dr. Nguyen, what do you think about the patient also having congested heart failure? It's not typical to have pneumonia and congested heart failure at the same time.
Hello, Phúc. I had to ask you because I was a little bit busy with a phone call from the hospital. I'm on call today. And can you go back to the physical examination? Because it shows that the no examination S3, we have S1, we have S3, we have cause crackles at the base of the left lungs and tactile inflammatus. Is it from consolidation of the lungs? Because tactile inflammatus, it is the consolidation.
yes,
And cause crackles, it is for pneumonia. Cause crackle. No JVD, and I'm not sure that the reason because for me, in a patient, when we say the patient had heart failure, that means the patient has fluid overload. Then we have to see, does the patient have fluid overload in the legs, in the abdominal wall area? The jugular vein distension is negative. What about the liver? Does the patient liver congestion? They have to have liver congestion before they have fluid in the lungs. That means the patient will have fluid overload from the area with low gravity, legs, edema in the abdominal wall, liver congestion, and then liver fluid in the lungs. We don't have a patient with fluid in the lungs and no liver congestion. It doesn't go that way. We have to have the fluid overload in the right heart system, and it go from the base first, from the leg first, and go up and go up and up, and then after when they have too much fluid in the right heart, at that time we have jugular vein distension. So we have to find that kind of scenario. I'm not sure that, and we don't have the echo here, so I'm not sure that the patient have heart failure yet. I remember, I'm not sure we're not Ian. You see a lot of patients with AIDS, but I did my training in New York City in 1980, 83, 84. This is a time when we had the first few cases of AIDS in the US. At that time, the patient have lung problem and no heart failure. I don't think they have heart failure here, especially it is 28 years old. You see? So, but the sign of oral candidiasis is not a acute problem. It's a chronic problem. That means the patient did have immunodepressed condition for quite a while. So to say that this patient is a brand new person, everything clean, suddenly develop pneumonia and have ARDS, maybe. But oral candidiasis, it is a chronic problem. It is a sign of chronic immunodepressed condition. It's not acute. Acute is what we are seeing now, the SIRS and the ARDS, but not oral candidiasis. Phúc, is HIV status, is it positive?
positive, doctor.
So I believe that this patient, and do we know that how long has he has been having AIDS, HIV positive?
He didn't know. He actually didn't know about he's having HIV.
Yeah,
So
but another one, he recently lost weight, right?
yes, he lost weight since he have onset of fever.
That means it is he had this condition. Let's say he had asymptomatic HIV positive for at least a year to develop this thing. You see, to lose weight and to have oral candidiasis. It's not acute condition. So Ian, this is my impression. And can you ask any student who have any comment about this case? Anybody is good in infectious disease?
Yes. So anybody here who have any comment or any question, please feel free to get question.
Okay, if we don't have any question, Ian, now your turn to so wrap up, and so you see what kind of what a message we have for this case.
Yeah, so very good presentation. So before we move on, how is your patient? Is this a real patient or this is a patient you saw?
He's a real patient. When he admitted to the hospital, just a day before I examined him. So he was treated with PCB. He was treated with PCB management, but he
So
yes.
What antibiotics did you guys give him initially?
I really don't read the management.
It's okay. It's okay. Okay, so very good. So obviously, I think Dr. Tak really made it a good point. Like, you know, like this is a patient that's not your straightforward pneumonia patient because he was exhibiting immunocompromised state. Absolutely, the oral candidiasis is not something that happens overnight. That's an opportunistic infection. So his HIV status was confirmed. So I think that the important thing now moving forward is you guys treated him for PCP pneumonia. I think there's a new name for that now. They don't call it PCP pneumonia anymore. I think it's Jernovia something pneumocystis. I don't know. Look that up. There's a new name for that organism now. So the next step probably is to see what his CD4 count is and to diagnose him if he has not just HIV, but AIDS, because that would mean that he would have to get more treatment. He would have to get, PCP prophylaxis for other opportunistic infections. But the ARDS diagnosis was excellent. How you got that from the computations you did. I'll be honest, we don't do that too much more in clinical. We usually do it with the CAT scan now. In the CAT scan, what you would see is ground glass opacities diffusely in both lungs. There would be a lot of little, it looks very different from congestive heart failure. So there's a lot of inflammation around the alveoli. That's why there's a specific treatment when they're ventilated, because what you want to do is reduce the barotrauma from the ventilator. Because if you over pressurize the alveoli, there's risk of more damage in the lungs. That's why I was asking you, what is the specific treatment for that? That's pretty much it. Pretty good. Anyone have any questions? No? Okay.
Okay, then let me conclude. Then first, I have to commend Phúc for have very good presentation. It had been a long time I didn't hear about this kind of HIV positive patient with PCP with opportunistic pneumonia is number one. Number two, Dr. Santos, as the chief of hospitalist at the hospital, is very good in your, you are well-rounded with all this this training and information about from intensive care medicine to hospital medicine. It's very beautiful because I am so focused in cardiology, so I don't remember, I don't know anything more about this kind of problem, ARDS, SEERS, and then with the treatment, with the barotrauma from ventilation. So it's very good. And it gives us quite a bit of information and to think about the problem and the approach the situation. And this is the way we do in the US. A doctor is well-rounded in training, and so this is why we look at the picture in a very good with an overview, and so we look at the whole picture, not just only focus in a limited area like a cardiology or something. So this is very good. You see, I am very happy. I learned quite a bit in this case. And for Fook, you present very good and very good case and quite good of information. But because you are, what year are you now? 4th year, 5th year, 6th year?
5th year, Master.
5th year, right?
Yes.
Yeah. This is why Fook, he says that he didn't pay much attention about the management, because usually we management for the 6th year. Is that right? So you focus more in pathophysiology. Okay.
I don't have enough time to read textbook because this patient has so much problem, and as I did mention here, he had like 5 problems, and I only have time to read ARDS, read about his acid base, about how to interpret blood gas arterial, and acute heart failure. Well, actually, yeah, his S3 didn't suggest me much about his heart failure actually, and I did write here that he could have hyperdynamic, or he could have diastolic dysfunction, just because of his hypotension, because of this infectious disease, septic shock, and I think that his ischemic heart disease could be a complication of combinations of hypotension, and I could show, and I really am just interested in the cardiomyopathy because it started to rise in like dramatically in this late century. So
one question before we finish, how's the result of the echo?
the patient didn't have echo. I don't know why.
It's okay. It's okay. It's fine. Okay. So I'm very happy. And Ian, we need you the next few times. Is it okay?
Thank you.
Of course. Give me a heads up, and I'm more than happy to. Very fun.
Yep. And I really enjoy the question, the interaction, and the way how to approach a problem and the thinking. And I appreciate you are here today with us. And I hope that